Good evening, everyone. I can see people joining us live. We're so glad to have you this evening for our AIM at Skin Cancer Symposium with the University of Wisconsin-Madison. If you will be patient with us, we need to wait about 30 seconds to let everyone load in on Zoom and Facebook and YouTube. I'm continuing to watch the numbers rise, and when it looks like we're all here, then I will start. Okay, let's get started. Good evening to everyone. I'm Ann Garst-Taylor. I'm the Director of Community Engagement for AIM at Melanoma, which is the parent company of AIM at Skin Cancer. And I'm going to have the opportunity later on to come back and talk to you about AIM at Skin Cancer. But I need to start by thanking the University of Wisconsin-Madison for hosting this evening's educational symposium, and Dr. Ma for serving as our moderator, and then, of course, our panelists for their collective wisdom. We know that you are going to have questions for our panelists this evening, and this is how we will handle those questions. You are welcome to submit them. If you are viewing via Zoom, then what you need to do is go down at the bottom of your screen. You will see a little tab there that says Q&A, and you can type your questions in there, and Dr. Ma will be able to see them there. If you are viewing via YouTube or Facebook, then you can put your questions into the comments fields and we'll bring them over and put them into the Q&A section for our panelists. And so with that, I am going to hand the baton to Dr. Ma to open up our symposium. Dr. Ma.
All right. Thank you, Anne, for the introduction. And thank you for inviting the University of Wisconsin to participate in the AIM at Skin Cancer Patient Symposium. And so my name is Dr. Vincent Ma, one of the medical oncologists at the UW Carbone Cancer Center, and I'll be hosting this evening's event. And so today we have a series lineup discussing topics on the evaluation and management of non-melanoma skin cancers to be presented by three presenters today, Dr. Burr, Dr. Shu, and myself, Dr. Ma. And so we also do have a planned Q&A session at the end of our presentations. And so without further ado, I will start off by introducing our first speaker. Dr. Adam Burr is an assistant professor, radiation oncologist in the Department of Human Oncology at the University of Wisconsin. His area of clinical focus and research is in head and neck cancer and skin cancer. He's a well-respected member of our multidisciplinary skin cancer team, and I'm very pleased to introduce his talk on radiation therapy for skin cancer, replacing fear with facts.
Just sharing my screen, 1 second. Okay. Excellent. Does that look correct, Vince?
I believe you're in presenter mode right now.
Oh, yeah, sure enough. Okay, does that work?
Perfect.
Okay, excellent. So thank you everyone for coming tonight. As you said, I'm going to try to turn everyone's first opinion about radiation, which is similar to the picture at the bottom, into thinking about it as just another tool for treating skin cancer. And so our brief overview, we're going to talk through skin cancer in 5 cases. We'll discuss what radiation therapy is, how does it compare to and complement surgery, when should we consider using radiation, and we'll look at some of the outcomes that we have with radiation. So what is radiation? And radiation is the use of high energy electrons or photons to treat skin cancer or really any cancer in the body. The mechanism of action for radiation, is through damage of DNA. And so the key mechanism is through double-strand breaks, as you can see in the bottom left there. And those lead to cell death as the cell tries to divide. And we deliver either with a linear accelerator or with a brachytherapy afterloader, and a typical treatment course lasts between 10 and 20 treatments, each lasting about 15 minutes each. And on this bottom right is really a diagram of kind of the basic 4 R's of radiobiology. So there is a whole science behind this that's been developed over the last 50 or 60 years that gives us our understanding of how radiation really works in these cells. And so does radiation really work? I think that's a common area to start with, radiation versus surgery. And so there was a large meta-analysis published in 2019 of about 21,000 patients. And just to cut to the chase, the local failure rate with our gold standard Mohs was 0.2%. Brachytherapy in these selected papers was 0%, and external beam radiation was 2%. And there's likely between the brachytherapy and external beam, there's obviously some selection biases we'll talk about tonight. But overall, all of those numbers are reasonably good. And brachytherapy and Mohs had a 97% good cosmetic outcome. External beam fell a little bit behind that at about 80%. And so all potentially good options for treating skin cancer. And so the first case I wanted to start with tonight is a small skin cancer. And this is a technique we use quite a bit at UW, and that's skin brachytherapy. And so this was a gentleman in his 70s who had this was his initial treatment, 2 small basal cell carcinomas, one on the tip of his nose, one in the preauricular region. And we measured the depth of these with ultrasound. They're both about 1 millimeter deep. And so we knew that these would be a good place to use brachytherapy. We have a few different applicators we can use. One is 2 centimeter in diameter, one is 3 centimeters. And his nose was actually fleshy enough that the 2 centimeter was able to fit flush to the nose. And so it ended up that that was actually a site we were able to use the brachytherapy applicator. And the advantages of brachytherapy in skin cancer are that it's a short course. It's only 8 treatments, about 15 minutes per treatment. It's a shallow depth, so it's only about 3 millimeter. It's only 3 millimeters to our prescription dose, and so that leads to excellent cosmesis because we're not treating very deep in these patients. And our control rate at UW, when we looked at our data in 2023, was 97%. We've since treated about 20 more patients, and we haven't had a failure in that cohort. So it does seem to be a treatment that we really favor in these small early lesions. The disadvantages, though, are similar. You are limited to shallow lesions, which is not all of the skin cancers that we see, and you need a flat surface to treat. And so that's also not where all the skin cancers occur. And this is just looking about 1.5 years later at his nose. You can see this little basal cell is now gone, and really an excellent cosmetic outcome. It's hard to say that he was treated with radiation to his nose. This is the applicator that we use. It's called the Valencia applicator from Electa. We gently hold this applicator against the skin with a clamp. That's how we do the procedure. The radiation seed enters through the back end of the applicator here and then dwells, as you can see right here, in the middle of the bell of the applicator. Each treatment is about 5 minutes in length. We calculate the length of each treatment before we deliver the radiation each day. And as the course goes on through those 8 treatments, the length of the radiation actually lengthens slightly as the source of the radiation, which is iridium-192, decays. And again, like we said in the last slide, we generally ultrasound for depth because we really don't want to be treating anything deeper than 2 millimeters with this technique. So that's brachytherapy, and it's our go-to technique for shallow superficial lesions. So word of caution is about this: not all superficial superficial brachytherapy is equivalent. And what we were talking about there is high dose radiation therapy using brachytherapy with iridium. And that really is a mature technique that's been around for many years with multiple prospective studies. This machine is regulated by the Nuclear Regulatory Commission. It's QA'd by a medical physicist every single day. And it treats with higher energies, 200 to 600 keV, which is in a range that is well understood biologically and dosimetrically. And so this is one type. The other type that we're starting to see out there is electronic brachytherapy. And this is more commonly occurring at dermatology offices and other practices. The reason it is because it's lower energy in this 50 to 70 keV range. It doesn't require shielding. It doesn't require regulation from the NRC. It doesn't really require the same QA, and the quality assurance that it requires is different state by state. And so there's some challenges with this technique currently. It lacks mature prospective studies. And so if you are going to be treated with this, I would encourage you to be treated on a prospective study. So you can contribute to the body of knowledge that will, hopefully someday show that this is a safe and effective treatment. There's greater uncertainty in the dose for a couple of reasons. One, it's possible that these low energy photons are biologically different. There's also a concern that there's greater dose gradients. These lower energies tend to fall off quicker than they do with iridium. And there's greater uncertainty. For example, over bone, you'll come in 7 to 10% low on dose with this technique because there isn't as much backscatter compared to standard techniques. And so it's also not typically given by radiation oncologists, although some practices have acquired these machines. And so I think this is an emerging technology and maybe one that will become important in the future, but one that we should use with caution currently. And there's currently 3 units on the market listed below. And this is these are the recommendations that come out of the American Brachytherapy Society's skin brachytherapy guidelines from 2020. So what about all the other skin cancers that aren't 2 millimeters in depth or less? And I chose kind of an extreme example here, but really anything else in skin cancer often can be treated with electrons, which is a different type of radiation therapy. In this case 2 is a 90-year-old man who's developed a number of large squamous cell carcinomas on his face and his neck. And at this point, he is no longer recommended to undergo Mohs for these. He's undergone a lot of Mohs in his life, and as he's got a lot of other comorbidities, and these are starting to pop up more frequently, felt like Mohs was not going to be his best option. And so they referred him to us to treat with electrons. And so we treated with an electron plan, and we were able to get complete responses in multiple lesions for this gentleman. The way we create these plans is you can see those marker dots there. What we do is we measure the diameter of that, and then we can create a circle in a compound called Cerabend, which is lead, that we are able to treat with radiation through. So the lead actually limits the area of radiation, and we get the radiation just in the circle we want. We can make it essentially any shape with this same technique. And so what are electrons? Electrons are charged particles that penetrate through the tissue to a fixed distance based on energy. And so the important number is how far can we treat with the kind of prescription depth, and that is the energy divided by 3. And so most clinics will have these 4 energies of electrons, 6, 9, 12, and 15, and those correspond to depths of 2, 3, 4, and 5 centimeters in depth. And below is a cartoon showing how this works. And so typically with electrons, we will use some bolus material because, as you can see at bottom right, the dose is not at 100% on the skin. So this bolus sort of tricks the electrons into being at 100% dose when they meet the cancer, and typically skin cancers are located superficially on the skin surface. And so this is our typical setup that we use day after day to treat the majority of skin cancers. And this gentleman, we use 10 treatments. 10 to 20 treatments is pretty common for our electron treatments. This is just another slide showing how we set it up. This is a linear accelerator pictured at left. The business end of it is just above the table there. That's where the electrons come out of. And they go through this apparatus called a cone, which collimates the electrons and then focuses them down to whatever our shape we want at the end of the cone. And essentially we turn this, $2 to $4 million machine into a gigantic flashlight. That's the way to think about this. And so we want that to be pointed perpendicular to the surface we're treating on the patient. And we can move the table, we can move the gantry is what the machine is called, the rotation, the mechanism by which it rotates. And we can also turn the collimator in the head of the machine to ensure that we are able to achieve that. But that's really the way I teach my residents to think about it, is we're just shining a flashlight on the patient. How do we move the patient? How do we move the machine to ensure that we're shining that flashlight perpendicular to the tumor? So that's electrons. That's by far our most common technique. However, some patients have cancers that occur on curved surfaces. One of those is the tip of the nose. And for this, we will often use photons to treat. And by far the most common way we do this is with 17 treatments, 51 gray and 17 fractions. We use these lateral beams, and that's how we tend to treat these, because the curved surfaces make it so that electrons can have an inhomogeneous dose. So you get a lot of dose at the surface of the nose, but a lower dose at the ala and near the skin surface. This is an example plan. This isn't the exact plan that this young lady was treated with. She had a squamous cell carcinoma on the tip of the nose with sort of indeterminate borders that were extending beyond where you see that little black dot. And so this is an example plan. We treat from a beam from both sides, and then you can see the dose distribution here on the right tends to be a very homogeneous dose distribution. And this is her nose approximately 3 months after completing treatment. Again, I think it's hard to say that she received radiation. Again, she has a good cosmetic outcome from that treatment. So getting into some more complicated types of skin cancer treatment, just as examples, these are treatments where we're using intensity modulated radiation. So we're using computers to optimize the area that we radiate and avoid a dose to certain structures and generate dose to other structures. So these are more advanced radiation techniques, but certainly well within the purview of most skin cancer, or most clinics that treat skin cancer. And so this is an example of a basal cell carcinoma that recurred several years after a patient underwent a conical bowl resection and reconstruction. And so it's really an extensive reconstruction. The patient, as well as the ENT providers, didn't really want to do a large resection and remove the entire ear, and felt that would be better suited with radiation. Given the interval, we got an MRI and we saw the cancer had invaded into bone as well as into the parotid, and we chose to radiate this using this technique. And we treated over 33 treatments, and we got a complete response, and now is the patient's approximately 2 years out from treatment and doing very well from it. And so this is an example where you can, instead of using surgery, use radiation and preserve this reconstruction and this normal appearing ear that this patient has. Another example of using this IMRT technique, this more advanced radiation planning technique, is in periorbital tumors. And the challenge with periorbital tumors is that the eye, they're challenging for both surgeons and radiation oncologists. Surgeons have challenges with the reconstruction. Our challenge as radiation oncologists is that the eye tolerates less radiation dose than is necessary to cure a skin cancer. And so how we get around that challenge is by actually shielding the eye, which you can see in the bottom right here. So we use a tungsten shield that's placed under the eyelid, and this blocks electron beam. And so what we'll do is we'll treat half of our dose typically with IMRT, half of the dose with electron beam. And then we use this shield to block that dose to the eye so that we can do this all safely. And so this is a way we can treat periorbital tumors, again, and achieve cures in these more complicated tumors by using a combination of techniques in the same patient. Another example of a complicated skin cancer. This is a patient I share with Dr. Ma, was treated actually with concurrent chemotherapy as well, but this is a patient with extensive perineural invasion. So it was a patient who had a year history of facial paralysis prior to presenting and determining that this was a skin cancer, and treating most of the facial nerve as well as the trigeminal nerve and most of the branches of those nerves to definitive radiation doses, and avoiding radiation dose to things like the brain and other parts of the head and neck, the salivary glands. And so again, this was a patient that we were able to manage a very complicated tumor with radiation and achieve long-term control of his disease. So what are the side effects of radiation? The main side effect is desquamation, or damage to the surface of the skin. That typically heals over 2 to 4 weeks. It heals quicker. We started following how dermatology treats these wounds, and it started to heal quicker. So we cover them with Vaseline and this Telfa gauze material, and they tend to heal over about 2 weeks. Long-term effects of radiation, one of the big ones is hair loss within the treatment field. That's an important consideration when we're thinking about definitively treating lesions. Sometimes we choose Mohs because we're worried about hair loss. About 10 to 15% of people will have decreased color or hypopigmentation, or dilated blood vessels called telangiectasias, or firmness of skin. And then anytime you give any radiation, there's always a risk of a second cancer. And estimating that in skin cancers is a little bit challenging, but somewhere between 1 in 100 and 1 in 1,000 are probably good estimates for a skin cancer, and your radiation oncologist can give you a more custom answer to the situation, depending on how big a field is treated and what dose is used. So considerations for definitive radiation. I think it's a good idea to consider radiation anytime we're treating a nose or an ear, or anytime a major reconstruction is needed. I think brachytherapy is an excellent choice for superficial lesions on the extremities, which are a challenging place to treat nose as well as the face. Surgery, I think, is favorable, or certainly around the hairline, because I think it's really hard to hide an area where radiation has permanently damaged the hair, especially along the hairline. In the middle of the head, in the middle of the scalp, it's easier to hide those defects, but on the hairline, it's more noticeable. And then radiation is also effective for larger unresectable lesions, but really have to make those decisions in a multidisciplinary fashion with medical oncology and surgery. We're going to talk really briefly as we wrap up here about adjuvant radiation. So this is radiation after surgery. This is sort of the previous guidelines for this, where basically, how do you find a needle in the haystack? You burn the haystack to the ground, and then you'll be left with a needle. But I think over the last 5 years, thanks to the work from Shlomo Koifin and some other people, we've really, as a field, started to refine the patients we treat with radiation. And I think that work is still ongoing. And so adjuvant radiation means radiation after the gross tumor has been removed. Radiation reduces the risk of recurrence in those tumors by 50 to 60%. And so the key is to estimate accurately the dose or the risk that the patient has of a recurrence after a resection. We know Brigham and Women's staging predicts this risk better than AJCC staging or any other method we currently have. And so the way we approach it at UW is we consider treatment for T2B lesions based on the staging system. We recommend treatment for people with T3 lesions or the rare patients who have positive margins. And generally in this adjuvant space, we're treating 17 to 20 fractions for most patients. This was a recent example. This is a 60-year-old gentleman with a squamous cell carcinoma of the ear, measured 6.7 centimeters with a 1.4 centimeter depth. Perineural invasion and lymphovascular invasion were present. This was a high-risk lesion. It was reconstructed with a skin graft, and we treated it to 50 gray and 20 fractions over 4 weeks. Did phenomenally well and healed within 2 weeks of treatment from the acute effects. So with that, thank you very much. Up next, I'll yield the rest of my time to Dr. Shu, who's up next. Thanks a lot.
Great. Thank you, Dr. Burr. So this is Dr. Ma here. So very comprehensive overview of radiation therapy and skin cancer. I do see here that we have a couple of questions already. So we really appreciate you all submitting your questions online on the Q&A. We will tentatively plan to answer all questions at the very end, but I would like to start off next by introducing our next speaker. So our next speaker is Dr. Gloria Shu. She is a professor and section chief of Mohs Dermatologic Surgery and the director of the Mohs, Micrographic Surgery and Dermatologic Oncology Fellowship in the Department of Dermatology at the University of Wisconsin. And the title of her talk will be Revisiting Basal Cell Carcinoma When Small C Becomes a Big C. So I'll have you take it away, Dr. Shu.
Thank you very much. Yeah, we tend to call fellowship a very awkward name. It's basically a Mohs fellowship, and we put in a very awkward long name. So I'm going to share my screen here. Someone else is sharing. I think Adam, you can stop sharing. Maybe close it. Yeah. Yeah, and I can do that. Let's see. Slideshow from very beginning. Can you all see okay?
It looks great.
Yeah, thank you. Yeah, good evening, everyone. Thanks for joining us. I'm very excited to talk about basal cell carcinoma. The reason being that basal cell carcinoma, usually it's very small, very early. They don't travel to the rest of the body, don't metastasize. But sometimes we do see some small seeds become big seeds. So I will talk about that in the latter part of my talk. No conflict of interest. So overview of my talk is we're going to actually look at just a basic information about basal cell cancer, such as epidemiology, risk factors, and how to prevent it, and typical clinical presentations, and showing a lot of pictures of the basal cell presentations. And then just talk about how we manage basal cell cancer when it's small and early, or when it's late, advanced stage. Epidemiology-wise, this is the most common of all cancers in the United States. It's estimated that annual incidence in the United States is 5.4 million basal cell and squamous cell carcinoma combined. So that 80% of them is basal cell cancer. So you do math, it's about 4.3 million every year. And estimated that lifetime risk is 1 out of 5. Or if it's your white skin, then it's a little bit more than that, 30% for your lifetime risk. So it's very common. And when you talk about basal cell cancer, almost like any type of cancer, you look at your phenotype, meaning that your makeup, your complexion, and also some environmental exposures, as well as a genetic predisposition. If you add 3 things together, then you have high risk for making basal cell cancer. So phenotypically, like you guys all know that if you're fair skin, red blonde hair, pale eyes, your skin would burn but never actually tan. And you also have like a high number of atypical moles. That is your phenotypical high risk, because this complexion will make you be more susceptible to sunburn. So environmental wise, UV damage is the #1 risk factor for all kinds of skin cancer, including basal cell carcinoma. Genetically speaking, there is a genetic condition called basal cell Nevis syndrome. These patients actually developed basal cell cancer in very young age because they have this most common gene mutation called a patch gene. There are other gene mutations less commonly involved, but when you have like a sporadic basal cell cancer, meaning that you don't have genetic mutation, but you just have this sporadic mutation in patch gene, that also give you basal cell cancer more commonly than the rest of the population. So if we look at UV, the most common risk factor, as I said, if you divide a UV based on the wavelength, the very short ones, like 100 nanometer, that actually called a UVC, that will never reach the Earth. It will be sort of reflect away by ozone. However, UVB and UVA does actually penetrate. As you can see from the arrow size, UVB is actually a little bit superficial, gets to in the lower part, it's your skin pathology, like it gets to the epidermis, which is the top of your skin. With UVA, however, it penetrates all the way through the epidermis, goes to the dermis. So basically kind of penetrate deeper and does more kind of delayed damage to your skin. So in general, UV actually involved in skin cancer formation of all kinds of skin cancer, as well as actually skin aging and also damage to the eye. So this is another diagram for you to see that studies have shown that actually both squamous cell carcinoma and squamous cell carcinoma, it's more related to accumulative exposure of lifelong sun exposure, versus basal cell melanoma, it's more intermittent sun exposure. But early on, during childhood, that UV damage is super important. So we teach kids how to do sun protection. And in terms of genetic predisposition, I'm not going to bore you guys with a complicated pathway, but just remember there is the main sort of a pathway that's involved in basal cell genetic component is called hedgehog pathway. What that means is actually this patch gene, as I said, it's mutated in some sporadic and genetic basal cell carcinoma. It's actually sitting on the membrane of cell. It's called a transmembrane receptor. It's patch gene made to the protein called a patch. Normally, as you can see, there is a red break over the smoothing. It's called a smoothing head. So basically it's put a break on, so the cells are not into like a crazy proliferation. However, if it's combined, it's bind by its hedgehog, it's a bind to the receptor. So ligand binds the receptor. And then this break is released off. And then you can have all the proliferation of the bad genes, like kind of promoting skin cancer formation. When you have a mutation of this patch, this transmembrane protein, then you actually, as if this is always on. You don't actually have the ligand binding anymore. It's always on. That's how this mechanism is utilized in the cancer treatment. So this is showing that a few examples here. This fosimidigib is one of the systemic treatment that we will touch upon a little bit later, but just showing you this is your target. Basically, you can actually lift instead of just like making this gene always turn on, you actually suppress it by these medications. So we'll come back later, but this tells you how cancer forms and also give you another view of how we actually control cancer or suppress cancer. Now, with any type of cancer, prevention is the most important thing, because once you have it, you have to treat it, right? So sunscreen and the rest of the sun protection means is very important. And you guys all know that sunscreen is one of the protection. And when you look for sunscreen, you look for SPF, sun protection factor 30 or higher, which block 96.7% sun rays. And you look for broad spectrum that block both UVA and UVB, as I already said. UVA penetrates deeper, and UVB kind of give you immediate redness. And they both do damage to your cell, DNA, cause skin cancer. And there's nothing water resistant, actually. A lot of sunscreen actually give you maybe 40, 80 minutes of water protection, but it's temporary. And the goal is really you have to reapply it when you sweat or get into water. If you don't apply sunscreen liberally to your skin, like a very thin layer, then even if you have SPF 30, it doesn't behave as SPF 30. It's lower than that. So keep that in mind as well. And then there's a lot of a lot of brand names, but there are two types of mechanisms. One is called like an inorganic zinc oxide as one example, and common names are also called some blocks, physical blockers. Basically, it scatters photons away from your skin versus on the right side, it's organic. Organic sunscreens basically is chemical absorbers. They absorb your sunscreen and make that into something non-harmful to your skin. So they have two different kinds. Sometimes people actually develop contact dermatitis to the chemical absorbers, not to the physical blockers. Let's move on to typical presentation of basal cell cancers. Most common one is called nodular basal cell cancer, 60% of them. Then you can have superficial, and some of them look much like a very subtle kind of scar-like, but they penetrate deeper. It's called infiltrative morphiiform. And there's some other uncommon types. I'm going to just show you some pictures. So this is a classical presentation of nodular basal cell cancer. As you can see, like a circling area, it's very subtle. We call translucent or pearly. That's the word we describe it. It looks like kind of shiny, right? And it's like usually it's an elevated bump. So this is a different location, different patients, but you can all pick up this little shiny color, and some of them actually has a little bit of a depressed center, because the necrotic cancer become necrotic in the center, and it kind of give you a little depressed center and a little bit of rolled up border. So that's, and the depressed center can cross over like with a little bit of scab. So those are common presentations. And sometimes I just put this slide in to show you that sometimes basal cell cancer can happen in protected area, like sun. This area doesn't see any sun. So it tells you that sun exposure is not the only reason. It's the most common risk factor, but it just takes some random mutations to form basal cell cancer in some protected area, as shown in this example. The pathology wise, the reason they call it nodular is you can actually see the nodules, like they form blue balls under microscope. So they call nodular basal cell as an example here. This is one example of superficial basal cell. So as you can see circled with purple marking pen, it looks like a rash, right? It looks like a little flat rash. It could be small, this small, it could be much larger. And they could look like just precancer called actinic keratosis. This is a little bit harder to tell for patients. And under microscope, as you can see, it's not a blue ball anymore. It's something sort of budding off of the skin surface called epidermis. So the budding off, and they could look like a just blue kind of purple looking lineup along the skin edge. That's superficial basal cell. It could grow pretty wide, but they don't grow deeper. So let's move on to another classical presentation of infiltrative or more multiform basal cell. They just look like a scar, or looks like just ill-defined with ill-defined border. Some of them are a little bit harder to tell, where it ends, where it starts. So that's more multiform. They actually tend to grow deeper. So if you look at pathology, you can see that the squiggly blue, structures, that's your basal cell cancer. Some of them can grow like around the nerve. These are high-risk basal cell cancers. And this is another example showing your basal cell cancer is like more infiltrative, like more deeper rooted. And there are some basal cell cancer look like pick up some color, pigmented. So you can, confuse that with the melanoma sometimes. So let's move on to treatment. When it's really small, this diagram kind of shows you when it's superficial and it's very small nodular basal cell cancer, you can actually treat just like destroy them with a destruction method. Some of them called like you can use liquid nitrogen, that's less commonly used, but some of them it's called electrodesiccation or curettage, which means that you scrape and burn. You scrape with a sharp tool, and then you burn with an electric cautery. Scrape and burn, you repeat 2 or 3 times. You can just get rid of this superficial or small nodular basal cell cancer. You can also try topical cream. I'll have some slides later. When it's more infiltrative or large nodular basal cell cancer, then you actually tend to do surgery. As we mentioned earlier, Mohs surgery is one type of a surgical treatment that can give you good margin control. Or you can do radiation therapy if patient is not a surgical candidate or have a lot of comorbidities to do surgery. When the cancer gets much bigger, then you actually have to think about, systemic treatment, as we shown earlier about hedgehog inhibitor, utilize that pathway to shut down that pathway, or some other chemotherapy that I can talk about a little bit later. So for low risk small basal cell cancer, as I said, electrodesiccation curettage is just a scrape and burn. We tend to use that in the trunk and extremity area, like it's cosmetically, it doesn't look really good. Showing an example here, it's a hypertrophic scar. They tend to form a little bit thicker scar. So your basal cell cancer is gone, like 95% of chance, but then you form a kind of, cosmetically non-appealing looking scar, and it could itch you a little bit. So we don't do that on the head and neck area, but you can do that on the trunk extremity. This is another method for low risk basal cell or small basal cell cancer called elliptical excision. Basically, you cut a little bit wider margin, like 4 or 5 millimeter around your basal cell cancer, and you make that in a football shape or eyelid shape, and you close down. So it's elliptical excision with a closure, and you cut with a blind margin, as I said. So you don't know if your margin guess is correct or not, but most of the time with a 4 or 5 millimeter margin, you got a 95% cure rate as well. And so for some low risk basal cell cancers, it's a very dense slide. I don't expect you to read through that, but just kind of show you and look at left column. You see some names, right? Imiquimod cream, 5-fluorouracil cream, and this cryotherapy is a name for just liquid nitrogen burn. And this PDT stands for basically photodynamic therapy with the blue light. Sometimes people do red light. Basically, PDT meaning that you paint a photosensitizer on patient's skin with a skin cancer, and then you actually shine some light on it. The interaction between photosensitizer and the light can introduce, can cause some inflammation reaction, and then inflammation can cause skin cancer removal. But all this can treat superficial skin cancer. They don't work if cancer is deeper rooted. So you have to pick and choose. And as you can see already, the efficacy of all these kind of treatments, and the highest ones like close to be 85%, right? And then some of them don't have like really long follow-up. If you follow patient longer, you might see even higher recurrence rate. So the recurrence rate, the cure rate is not greatest, but topical treatment is good in a way to avoid skin cancer, surgery. Now, just showing you some example with the topical treatment, what that means. So this is a 5-fluorouracil. This patient actually treated a whole face and not just skin cancer, this treatment for pre-cancer. You can see very exuberant inflammation. And this is another one treating with another topical cream called imiquimod. You can see that it's really kind of uncomfortable, red, inflamed, almost like getting a little bit of a skin desquamation, and sometimes people could get secondary staph aureus infection because skin is all eroded. But 2 weeks later, it's already kind of calmed down. So it's a good treatment for superficial, or non-surgical candidate patients. And when we look at basal cell cancer, sometimes you actually look at, you kind of know it's a high risk. A lot of words here, but, common sense. If you look at basal cell, it's really large. It's kind of looking deep, kind of ulcerated on the surface. And with the pathology, biopsy pathology already telling you that it's infiltrative, it's actually wrapped around the nerve, or patients already like developed skin cancer in the prior radiation field, or they're immunosuppressed, like organ transplantation. All this kind of tells you this basal cell cancer, it could be not a small C anymore, it could be a big C. And then we also look at this like a mask area that's kind of high risk area on the face that they tend to have more aggressive skin cancers. So when it's high risk, we actually treat with the Mohs surgery. That we are very proud to say that Mohs surgery, for some of you don't know, Mohs surgery is started from UW with Dr. Mohs years ago. So it's a type of skin cancer that you actually want a skin cancer grow like contiguously, and you also want a skin cancer localized on the skin for a long time before we can treat them, right? And then before they spread to the brain or lung. So if they actually grow like this, then you can actually use Mohs surgery. So what Mohs surgery does is you can trace each skin cancer focal area to its entirety. You cut it out. But if they break down into local areas, they skip around, then there's no use, because you can get one cancer out, but there's ½ inch around your area, you have another skin cancer. So you want a skin cancer kind of grow contiguously, and happen to be all these common skin cancers. It kind of fit that criteria. Okay, I'm not gonna bore you with all these like Mohs technique, and just kind of to say that examples of treated with the Mohs tend to be on the face, critical areas like the ear, we treat with Mohs, we close it. This is the face by the lip, months follow-up looks good. This is the nose. We kind of, most of the patients we can repair on the same day because we got clear margin the same day. And this, I put a graft on it on the nose, and this is another nose defect. So a few minutes we left, and I'm going to talk about when the small C becomes big C. This is like a lot of times we tell patients like basal cell slow growing, it's okay to wait a little bit, but once we discover it, we need to treat it. This patient actually has a lot of comorbidity like dementia, so 2 years ago, my derm colleague actually looked at him and say, well, the family want to watch. So they watch it, recently we saw him, and just after 2 years, it's grow into this cauliflower looking, quarter size. And the patient still didn't want to do any surgery. So I think he just saw Dr. Edinburgh recently, and a treatment with local radiation is on the way. But I have to say that radiation and Mohs, we both have, great outcome, but with any treatment, when it gets more advanced, bigger and larger and deeper, the cure rate tends to drop. So this is considered actually a large basal cell cancer. This is another sad example here that I treated this patient 11 years ago. When he came to see me, it was already kind of treated and recurrent. So I was treating recurrent cancer, and I couldn't really get positive, negative margin. Like there's deep margin there, positive, but I cannot cut anymore because it get down to the bone. So we send the patient for reconstruction and then post-op radiation. For some reason, it's an outside referral. For some reason, the patient just did not go through radiation, post-op radiation, adjuvant radiation, but he did get good closure, flap closure. And 11 years later, he had a very subtle little opening in the flap. This is a scar area, right? Flap area. And the biopsy of these little spots showed basal cell cancer. Came back to see me, I did a Mohs again. So this recent Mohs show that this yellow circle set shows that I get down to the bone again, I cannot get him clear. So all this will be positive with all the skin cancers and sent to plastic surgeon. I hope they will actually chisel the bone out, ENT and plastic, and they put a graft on, a flap on. And I, again, recommended a radiation therapy. So this recent case, I hope he does well. This is another example of a neglected basal cell for years. You can see that it gets to the corner of the eye. So this is a Mohs and an adjuvant radiation that we handled with the radiation oncologist together. And it repaired by facial plastic and oculoplastic at the same time. So this patient is under close surveillance for now. Sometimes if you actually cut patient's nose out significantly, then nobody actually can reconstruct really well, and patient can consider a prosthetic nose or ear. They actually look pretty decent. This is another example that I shared this case with the Dr. Mar, and the patient had a neglected basal cell, in the corner of the eye. She didn't really want any radiation or any surgery, so she did a systemic vismodegib. I think she had a good response, but I don't have a follow-up picture. I'm just showing you a picture I borrowed from a literature, and some of the patients with a response, if they got a good response, they can have a good good outcome. However, the problem with all these treatment here, this hedgehog inhibitor, is that if you stop medication, majority of them will come back. They just sounds like this medication will just suppress it instead of killing the cancer. So if you look at this like a systemic review paper, again, I'm not going to bore you with all these little words, but just look at it. These words like vismodegib and sunitinib, you look at the complete and partial response rate, it's like nothing like more than 35%. So basically a quarter of patient will respond. And if you stop treatment, they will recur, most of them. And also some patient couldn't tolerate with the side effects. The last bottom one here, I'm not going to get into details. That's like a different, the bottom one, the third one is a different mechanism. It's called a PD-1 inhibitor. That's actually a new immunotherapy that's used in the squamous cell cancer and then used in basal cell cancer as well. I know Dr. Ma will touch upon immunotherapy with the Merkel cell. They all share similar mechanism. They basically kind of recruit your immune system to fight against skin cancer or some other cancers as well. This is a newer and looks like the complete response rate is lower. However, with time, if you have a good candidate, the good advantage of this immunotherapy is if you have a good candidate, the patient's the right candidate, they might actually have prolonged, endurable response. So the data is still new, and we have more to learn. Okay, thank you very much. My last slide.
Excellent. Well, thank you, Dr. Xu, for that excellent overview of basal cell carcinoma management. So we'll actually now, I just want to make a quick comment. I know that we have actually several questions coming through right now on, I believe, Facebook Live, but just as a reminder for some of you who may be joining, we'll be answering questions at the very end of our lecture series. And so I will actually be the final speaker for this evening. And so I will try to share my slides. All right. So I hope everyone can see my slides okay and can hear me well. And so just to briefly introduce myself, so my name is Dr. Vincent Ma. I'm one of the medical oncologists here at the University of Wisconsin Carbone Cancer Center. My area of clinical and research focus is actually in both melanoma and advanced stages of skin cancer. And so today, I actually have the honor and privilege of being able to talk about a very interesting topic. And so the title of my talk is Unraveling the Mysteries of Merkel Cell Carcinoma. These are my disclosures. And so one of the things I'd like to talk about is, what is Merkel cell carcinoma? So unless you've been diagnosed with this disease, or if you know a loved one who's been diagnosed with this, there's a really good chance you've probably never heard of this cancer. And the reason for that is it is an extremely rare type of skin cancer. In fact, when we talk about how often and the incidence for which we diagnose this cancer each year, there's only about 3,000 to 3,500 cases diagnosed each year in the United States. And so when you compare that, for example, to other cancers like prostate cancer or breast cancer, each of those cancers have a diagnosis of 300,000 per year in the United States. So almost 100-fold more frequent incidence than Merkel cell. Now, what do you need to know about Merkel cell is that compared to sort of the majority, if not all the skin cancers, it is quite aggressive and relatively fast growing. It's not uncommon to see a Merkel cell nearly double in size in a very short period of time, even a matter of short weeks. And so when we compare sort of the prognosis of Merkel cell compared to some of the other skin cancers, it is considered one of the deadlier skin cancers, if not the deadliest. Some of the studies have suggested that Merkel cell is about 3 to 5 times deadlier than melanoma. And so if you look at, for example, like the survival or prognosis of this disease, if diagnosed at an early stage or a localized setting, the 5-year survival is about 75%, whereas if the disease is diagnosed at advanced stages, the 5-year survival is much more dismal at about 24%. And so if you look at the bottom right figure there, I think something to kind of worry about, especially as a group of skin cancer specialists, is that Merkel cell, for some reason, is increasing in incidence each year in the United States. And the reason for that still continues to be somewhat unclear. Now, there's been sort of a lot of attention about Merkel cell after the recent passing of Jimmy Buffett, who, as many of you may know, is the Margaritaville singer. And so really his death due to this cancer has really brought sort of a spotlight on Merkel cell carcinoma, has really brought some increased awareness of this disease. But there are other famous individuals who have been diagnosed and have really succumbed to this disease, including, for example, Maria Bueno, a famous Brazilian tennis player who's won many major titles in tennis. We also have Al Copeland, who is a US entrepreneur and is the founder of the Popeyes fast food restaurant. But following his passing, his legacy has led to sort of the founding of the Al Copeland Foundation, which has really led to fundraising for dollar amounts to really help fund a lot of Merkel cell carcinoma research. And so when people are sort of worried about, this Merkel cell carcinoma, what are some of the features and what do I need to look for, with this type of disease? So the way Merkel cell can look is that it tends to appear as sort of like a red, maybe purplish type of little lump or bump. It tends to appear very firm on exam. It usually is quite painless. Most patients don't have much in terms of symptoms. It can commonly be found in the face and neck region, which is the most common location. We also find it in the limbs, like your arms and legs, and occasionally in the trunk. This cancer can frequently be misdiagnosed or missed, can oftentimes appear to be like a benign condition, like a cyst or a lipoma. And what's very interesting about this Merkel cell carcinoma skin cancer is that in about 15 to 20% of cases, this cancer can be discovered without actually being discovered on the skin. You can actually detect or discover it, for example, in a lymph node at first diagnosis. And ultimately, when evaluating for Merkel cells, that it usually needs to be diagnosed by a biopsy. No actual exam or imaging can clearly diagnose it other than a true biopsy. So I have here several images just of some examples of what Merkel cell carcinoma looks like. Illustrated here, we see that it can appear on the foot, in the face, so anywhere along the ears, the eyelid, even nearby the nose, for example. Now, what are some of the risk factors and warning signs of Merkel cell carcinoma? And so what I usually tend to think about is the mnemonic, AEIOU. So A representing asymptomatic, meaning having no symptoms or very little symptoms. E representing expanding. So this is a cancer, as I mentioned, that grows very rapidly. I is for immunosuppressed state. So we tend to see this cancer primarily in individuals who have chronic immunosuppressant medication use, people who've had a history of organ transplants like kidney transplant, pancreas transplant, cardiac transplants, and also individuals with HIV and AIDS. There's also a cancer we tend to see in the more older population, usually those older than the age of 60. In the patients I tend to see, they're usually in the ages of around 70s or so. And in addition, this is a cancer that is typically associated with lots of UV or sun exposure. So really, we tend to see this in areas where there's a lot of sun exposure in the skin. Other risk factors that don't fit into the mnemonic include individuals with light skin color. So this is a cancer we tend to see more often in whites as compared to other racial ethnic groups. And what's very interesting that we've learned over the past couple decades is that Merkel cell polyomavirus, which is a very unique virus that we actually have discovered to be in about 50 to 80% of all Merkel cell tumors. And so its impact on sort of prognosis remains somewhat unclear, but there are some studies to suggest that having your Merkel cell cancer with the virus may actually lead to a much better prognosis. Now, whenever one is diagnosed, with Merkel cell, not only is a biopsy needed to confirm it, we oftentimes need to do a couple sets of other tests and examinations, one of which is a comprehensive skin exam and lymph node exam. And the other is that we'll oftentimes incorporate imaging like MRI, CTs, and PET scans to evaluate for the disease. And the reason behind that is that we really need to properly stage the cancer. As mentioned, we oftentimes want and hope that we identify the cancer at an earlier stage. And similar to other cancers, we stage Merkel cell in stages 0 to 4. And so for the earlier stages between 0 to 2, the Merkel cell is really just confined to the skin. And depending on how large it is, sways it into, say, stage 0 versus 2. And when you get to stage 3, that refers to the cancer having spread to nearby lymph nodes. And so if you look at the figure to the right, this is an image of a PET scan where you can see that pointed by the yellow arrows, the bottom part is that the Merkel cell is located on the foot and has actually spread, for example, to lymph nodes up in the groin area, which is represented in sort of that white appearance. And so in that particular case, it would be a stage 3. Now, stage 4 is where you're in the late stage where the disease has spread to other areas of the body, like the lung, the bones, the liver, and even the brain. So that we consider more of the terminal or late stage. Now, whenever somebody is diagnosed with Merkel cell, people often wonder, where should I ideally get treated? And so I often recommend, especially for patients diagnosed with a very rare and aggressive cancer, that you be referred or have a second opinion at an academic center. And really the reason behind that is that usually at these academic centers, there's a larger volume that tends to be referred there for more of the rare cancers. And so you oftentimes want specialists, those who really know very much their own specialty of how to effectively treat Merkel cell on their own essential level of expertise. And so we oftentimes have what we call a multidisciplinary team. So people who are experts within their own field, such as dermatology, pathology, radiology, surgical oncology, surgeons in general and radiation oncologists and medical oncologists, those who, again, have the expertise and ability to know how to provide their input on managing these rare and complex cancers. And so, the figures here to the right, I have photos of members within our UW skin cancer team. And I'm very proud and privileged to work with just amazing colleagues who have really just wonderful perspectives, using their amazing knowledge and techniques to effectively treat rare cancers. And so for those who are kind of wondering, where, for example, can I find these experts or these academic centers? And one particular resource that I'd like to highlight is merkelcell.org. And so this is a website that I will occasionally recommend to my patients if you want to obtain resources to learn more about Merkel cell carcinoma, but is also an area where you can find a specialist, where you can find those who have self-identified themselves as Merkel cell experts. And you can again filter it based on the location or the state you're in, so that you can eventually or consider having an opinion or referral or even a second opinion about your diagnosis. How do you treat Merkel cell carcinoma? And so, like many cancers, we have to think about the three modalities or the pillars of treating cancer. And they include surgery, radiation therapy, and medicine. And so with a rare cancer like this, you oftentimes want a multidisciplinary discussion where complex cases are discussed in a tumor board. And a tumor board is really where we have a collection of cancer doctors and specialists that review very complex and rare cancer cases so that we can all come to a consensus or a unified decision on how best to treat the cancer. And so I'll kind of walk through some of the possible treatment avenues. And starting off with surgery, surgery is really considered the mainstay management of treating Merkel cell, predominantly if it is identified in the earlier stage. Usually with surgery, we'll do what we call a wide margin excision, where we not only remove the primary tumor, but we'll often sometimes remove sort of a larger margin, including some normal skin surrounding the tumor, with the hope that you'll remove any potentially microscopic disease around the edges. Frequently, the surgeons may often do what we call a sentinel lymph node biopsy, where they'll also remove the nearest set of lymph nodes that the cancer is likely to spread to. And you can evaluate these lymph nodes on a very microscopic level to know if the cancer has spread there. Now, on occasion, if the Merkel cell has spread to the lymph node, that Merkel cell tumor can grow and cause the lymph node to be enlarged, where you can actually feel it on exam or on a CT or PET scan, for example, in which case the surgeons can often pursue what we call a lymph node dissection, where you can remove a large chunk of that lymph node and sometimes some adjacent or nearby lymph nodes that might be affected. Next, we'll talk about radiation therapy. I know Dr. Berg sort of highlighted, the wonderful aspects of using radiation therapy as a means for treating skin cancer. And like other skin cancer, Merkel cell is also a disease that can also respond well to it. In fact, we even consider Merkel cell to be very responsive to radiation therapy compared to some other cancers. On occasion, we can use radiation therapy as an alternative to surgery, but is dependent and is really determined on a case-by-case situation. Now, radiation therapy is frequently incorporated into the treatment plan, oftentimes being delivered to the site of where the surgeon had operated on to remove the Merkel cell. And so frequently, and currently as standard of care, we'll often consider sort of a 5 to 6 week duration of therapy, which accounts to about 5 days per week over 5 to 6. But there is now some evolving data and some research to suggest that maybe we don't need to use the full course, and maybe even just one treatment over 1 day may be sufficient enough to effectively treat the disease and really to help prevent Merkel cell from recurring. And finally, radiation therapy can be incorporated as a means for palliation, meaning to help control symptoms, particularly if those who have Merkel cell where the tumor is causing pain or swelling. Finally, I'll talk a little bit about medicines used to treat Merkel cell. And this is kind of the area that I primarily focus on. And so medicines, and particularly systemic therapy, treatment that works on the whole body, can be incorporated into the treatment plan of Merkel cell. And we'll oftentimes incorporate that if the disease is in more of an advanced stage setting, especially where we know where surgery and radiation therapy maybe cannot be done initially to treat or even cure Merkel cell. And so amongst all the systemic treatment options that are available nowadays, the preferred treatment that we like to use is immunotherapy. And you can see there boxed in red. So we actually have several FDA-approved immunotherapy drugs that are available. And so the three ones that are FDA-approved right now for Merkel cell are pembrolizumab or Keytruda. The other one is avelumab or Bavencio, and the other is retifanlimab or Zynyz. There's a couple of other immunotherapy drugs that are also used sort of off-label, but can also be used as well to treat Merkel cell. And so just to provide a very brief highlight of how immunotherapy works, it's really a set of drugs, antibody drugs that we give by IV that sort of help lift the brakes off your immune system to essentially get your immune system to attack and hopefully eliminate the cancer cells from your body. So it's a really new novel approach that we've really discovered over the past decade, not only to treat other cancers, but now even Merkel cell. Other options we can consider, certainly on a case-by-case basis, if immunotherapy, for example, is not a good option, is chemotherapy. Chemotherapy does work very well for Merkel cell, but the only problem with it is that the benefit is great in the beginning, but the resistance occurs fairly quickly. Other drugs we can use that are off-label, pazopanib. There's also T-VEC, which is an intratumoral virus therapy where you can inject a virus directly into the tumor. And then, of course, we have clinical trials, which are options that we can consider for patients where maybe there are no FDA-approved drugs available after progressing on immunotherapy and chemo. And so as you can imagine, with this being such a rare cancer, I always say if a clinical trial is available, it's an opportunity to get an option that might be better than even standard of care. And so these are opportunities to hopefully develop newer and better drugs that might be one day be available to not only treat you or patients or your loved ones, but also future generations to come as well. So as a medical oncologist, I'm always impressed and in awe whenever I use some of these drugs in my clinic. And so how well does immunotherapy work? I have here a patient who has Merkel cell on the foot and wasn't a good candidate for surgery or radiation, but we ultimately decided to give her some immunotherapy. And you can clearly see here that even without surgery, without radiation, that you can get a really wonderful response to treatment, even as short as even 2 months of exposure to therapy. Now, for those individuals who were able to undergo successful surgery and radiation to cure Merkel cell, we'll oftentimes incorporate some degree of monitoring for recurrence of Merkel cell. And so some of the modalities we'll consider include getting a PET scan, for example. And we tend to do this primarily for patients who have more of the higher risk disease. And the frequency of it really depends on the individual and the features of the cancer. So we may do these, for example, every 3 or every 12 months, somewhere even in between. Full body skin exams and lymph node exams should be incorporated into monitoring and management. And so we'll often recommend doing skin checks every 3 to 6 months for the first 3 years after diagnosis, and then spacing it out over time thereafter. And then another blood test that you may hear of, especially if you've been diagnosed with Merkel cell carcinoma, is a test called AMARC. And this is basically a relatively new antibody test that's been developed over the last few years, has been validated in clinical studies, which essentially is a measurement of antibodies that attack specific proteins associated with the Merkel cell polyoma virus. And so if you have a detectable antibody at baseline, say before surgery, you can actually monitor that titer over time and you expect it to decrease, if not become undetectable in the months to come. But if you see that the levels rise, that may be an indicator that you may need to, for example, do more frequent PET imaging to detect the recurrence of Merkel cell. And so we'll occasionally check these levels anywhere from every 3 to every 6 months as part of the surveillance plan. Now, there is some ongoing research using or looking at other blood tests for surveillance of Merkel cell. And so here at the UW Carbone Cancer Center, we are looking at, for example, at circulating tumor cells, which are basically cells in the bloodstream of the cancer that we can actually detect by blood. And so we can actually calculate or determine the number of cancer cells in the blood. We can look at some of the proteins of the cancer cells in the blood. And so that we can identify, for example, markers that might infer resistance, for example, to treatment. So this is an area of ongoing development and research, even as close to you and here at the University of Wisconsin. But there is a new and more recently commercially available test that's being used called Signatera, where you can actually look at, for example, DNA of your cancer in the blood. And so I have been incorporating some of this into my practice where you can actually evaluate, for example, levels of Merkel cell DNA in your blood and quantify it over time. And so, for example, looking at Signatera, which is that circulating tumor DNA or Merkel cell DNA that you can check for, I have here on the top a patient who, for example, was diagnosed with Merkel cell, and you can see that level rise over time, seemingly to suggest that as I had introduced immunotherapy or treatment in the middle of that course, that level rising would make me suggest or make me feel that the cancer is not responding to therapy. So this is a sort of an alternative way to really know how well patients are responding to treatment without relying on the PET imaging or CT imaging. And then the bottom figure is really a really positive response to treatment, where when I introduce, for example, immunotherapy after a detectable level of Merkel cell DNA, we can see that level become undetectable. And so again, this is a new and revolutionary way for us to be able to better monitor disease throughout the course of treatment, and also can be used as a means for surveillance as well. Now, I definitely want an opportunity just kind of briefly to highlight this, but are there some drugs that are being explored right now to better treat Merkel cell? And I have to say, absolutely. There's a lot of hope for the future, that there are many trials that are at least coming into the space of Merkel cell. And so, for example, people have wondered, can I use adjuvant immunotherapy, meaning using immunotherapy after surgery as a means to prevent Merkel cell from coming back? And the answer is yes. There are some studies looking at the role of immunotherapy to be given after surgery. And so as of right now, some of those larger studies have since closed, but right now we're really waiting for the results of this to come back to really know, for example, does immunotherapy help prevent Merkel cell in an earlier state? And so we hope to have some of these results within the next year or so. But there are some other studies that are looking at new drug combinations in combination with immunotherapy, lots of new drugs with very new mechanisms of actions, new immunomodulators, new ways to essentially help stimulate the immune system, get your immune system to work a lot better in terms of eliminating the cancer from the body. And so, I've highlighted some of these trials here, but people often wonder, how can I know, for example, if the clinical trials are right for me, and where can I find them, for example? And so this is a sort of a resource that many doctors will use, and for those individuals who want to play a very proactive role in looking at options, you can go on clinicaltrials.gov and type in your disease. And so looking at your condition, such as Merkel cell carcinoma, you can actually filter your search by looking at studies that, for example, are near your home, studies that are now open, and really identify some studies that may be around sort of in the region that you live. And this is an opportunity for you to, and sort of as physicians, to really look at options for patients, especially when patients are faced with a very rare cancer diagnosis, and in circumstances where, for example, standard of care options may not be feasible. Maybe clinical trials might be a good option for you. And as I said earlier, clinical trials are a way, for example, to essentially identify new drugs that might be potentially better than standard of care. And then finally, I know Anne is going to be talking about some helpful resources through AIM at Skin Cancer, but I do want to, as I mentioned, highlight just a couple of resources that are available for those who may be diagnosed with Merkel cell or loved ones that you know. And so earlier I mentioned merkelcell.org, a great resource to look for just some helpful information about treatment, finding a specialist, for example, joining a support group. These are just kind of, and skincancer.org is also another wonderful reference that I will occasionally recommend for my patients to go to. As I said, just to kind of learn a little bit more about some of the newer advancements associated with Merkel cell carcinoma, and with skincancer.org also being another reference for looking at other skin cancers that you or your loved ones may be diagnosed with. And so with that, I really appreciate you all for listening. And at this time, I'd like to hand this over to Anne, and then we'll probably follow this up with a Q&A session.
That's great. Thank you so much, Dr. Ma. Thank you for giving me just a moment to talk about AIM at Skin Cancer and our amazing new website that we launched just in January. It is filled with educational information on a variety of different kinds of skin cancer. And we have done that because we believe that a well-informed patient makes better choices for their care. And I certainly hope that our clinicians this evening will agree with me. Certainly, the most frequently visited pages are those on diagnosis, staging, relevant treatment, and side effect management. But I want to, there are some noteworthy sections that I want to take a minute to talk about. The first one is our image library. It has 50 plus images of, again, a variety of different kinds of skin cancer on the full spectrum of skin types. In addition to that, we have a section on caregiving. Caregivers are often involved in many of the important decisions, and so we wanted to offer some guidance on how they could best support the patient in their life. We also have a service called Ask a Skin Cancer Nurse. Krista Rubin is an oncology PA who has 30 plus years of experience. And this is a free and confidential way that you can ask questions so that you can best understand the treatment options that your care team is discussing with you. And then lastly, we have a media library. We have a number of webinars, but in addition to that, the symposiums go on there as well. So what we will do with the symposium this evening is we will take and divide each one of the presentations up by topic, and then we will put them back onto our website so that you can watch them again and again. So if you have any questions, if I can guide you to something on our website, please contact me, and I will put my contact information into the comments and the Q&A tab here on Zoom. And with that, I'll invite Dr. Xu and Dr. Burr and Dr. Ma to turn their cameras back on again, and we will answer your questions. Thank you so much.
Thank you, Anne. I'm trying to see if I can start my video, but I'm having a little bit of technical difficulties.
Says you cannot start your video because the host has stopped it. You can hear me though.
Yes, I can hear you, Dr. Xu.
Okay.
I'm not sure why you can't turn. We have Anna. Can you fix it where they can turn their cameras back on again? There they are.
Oh, now it's yeah.
All right. Excellent.
Solve the problem.
Yes.
Thank you.
Yes, I'll invite all of our speakers to have our cameras on. And so what we'll start off with is we'll kind of go through some of the questions that have been posted so far. And so we'll probably start off with the top question that we have. And I'll certainly go through some of the ones that have also been posted on Facebook Live. But we'll start off with the first question, which is, I believe this would be a good question for Dr. Burr to answer, but how many hospitals or clinics are using brachytherapy or radiation therapy for BCC and SCC?
It's a great question. I would say it's a minority of clinics, but a lot of the bigger academic centers do have access to it. Also, ProHealth here in Wisconsin, down in Oconomowoc, I believe, is also using it to treat skin cancer. So, and I think it's also a growing area. So, an area we're going to see more and more clinics employing that technique. Another really common orthovoltage, or another common superficial radiation technique that we see is orthovoltage, and that can be another good option for superficial techniques. So I'd say mainly academic centers right now, but a growing population of people that are excited about brachytherapy and that are doing it.
Excellent, thank you. We also have another question, I think, also sort of relates to radiation therapy as well. So a little bit of a narrative, but I'm happy to go through it. So the patient, a person here who says, I'm in Australia and I was diagnosed with Merkel cell carcinoma on my left arm in 2000. There were only a small number of cells found in my axilla, but my treatment was radiation only. I had a follow-up PET scan for 2 years and 6 months and physical exam only since then, and I'm concerned that the cancer may return and not be detected without PET scan. My oncologist says that I'm now regarded as low risk. Is this approach appropriate? I think maybe Dr. Burr and myself can kind of tag team this, but Dr. Burr, how do you sort of counsel patients, after getting definitive radiotherapy for treating Merkel cell? What is your counseling in terms of expectations and potentially prognosis?
I mean, it obviously depends on stage. For early stage Merkel cells, I think the prognosis can be quite good for radiation in terms of local regional control. Obviously, the way we tend to monitor Merkel cell here at UW is we refer them to Dr. Ma. And so that has been a really effective strategy for monitoring Merkel cell, and one that works really well. I think I agree with your oncologist, though. You're 24 years out from treatment. Merkel cell tends to be a fast-growing cancer, and so most of the action, most of the concern, most of the risk is in those first year really after treatment, and certainly the first 2 years. So I think you're probably in good shape, but that's how we do it. We refer them to Dr. Ma.
Well, thank you, Dr. Burr, for the compliment. But I mean, just to kind of follow up, I think Dr. Burr really nailed it. For a lot of these patients where, after getting definitive treatment with either surgery or radiation, sort of the longer you go out after the initial diagnosis and treatment, the lower risk in general that this disease is likely to come back. And so the monitoring that was done, such as serial PET scans, physical exams to monitor for recurrence, is usually quite, frequent in the beginning, but then is spaced out over time. And really the most reassuring thing is that the further you go out, as you said, the likelihood of recurrence becomes even lower. And nowadays we're developing new and more sophisticated technology to help better detect, Merkel cell, for example, and likely other skin cancers. And so that could one day be someday maybe even incorporated into the surveillance plan. But I think overall what this person who has posted this has probably received, pretty appropriate care. The other question that's also come up is, and I think this would be a very appropriate question for Dr. Burr, who's really dealt with a lot of sort of the periorbital skin cancers, but can titanium eye shield be used when radiation is used to treat basal cell carcinoma in the temple area?
You can. So in the temple, what I really worry about most commonly is actually the lacrimal gland. And so that's located on the lateral aspects of the eye, protected somewhat by the bony orbit. And so what I'll often use for temple lesions is I'll use a piece of 3 millimeter thick lead that we cover in red wax, and then we cover the eye and we'll kind of bend it sort of at the corner of the eye to help do what we call surface collimation, where we block the radiation as it hits the surface of the skin, and prevent it from entering into that lacrimal gland in the eye. That's if you're using electrons, then shielding works. If you're using photons and IMRT, we can plan around the eye from a temporal lesion. You can plan around the eye with IMRT, so the dose will be very low. So it depends on the technique. You can't block X-rays with really anything except several feet of concrete, but you can block electrons, and so that's kind of the decision we make, and I'm sure your radiation oncologist is well aware of all of that.
Excellent. And so I actually have a question that might maybe a good question, or maybe sort of a statement and maybe some reassurance that can be discussed by both Dr. Xu and Dr. Burr, but this is a Facebook Live question. My family is currently faced with making difficult treatment decisions around a squamous cell, a cancer spot on the upper chest of my 96-year-old mom. It has not spread to her lymph nodes, but after meeting with a surgeon, while surgery is the best recommended treatment, her skin is so thin, the surgeon isn't sure they'll be able to close it, leaving an open wound to care for. And so they're really worried about infection, pain, and management and her quality of life. And so they're planning to meet with the radiation oncologist in a few weeks. And so, they just don't want the cure to be worse than the disease. And so this person asks a question. They raise this issue because there's so many factors that come into play with making the best decision. And so, when it comes to decisions between, say, for example, surgery versus radiation therapy, what's oftentimes is sort of the dynamic between, both the surgeon, so Dr. Chu, who does, Mohs surgery, and Dr. Burr, how do you guys sort of grapple with sort of these complex cases and older patients, to best find the best treatment for them?
Adam, you want me to go first?
Sure.
Yeah, I think we have this kind of conversation in real life, over and over. I would say it's a really just honest discussion, right? With patient's family, their caregiver, and part of attorney. And we always say that you treat patient as a human being, as a patient, not just as a skin lesion or skin cancer on the chest. So it's just kind of complicated, and you cannot generalize it. But the point's well taken, like all these factors have to be taken into consideration. Can the patient, undergo like lengthy procedure? Sometimes procedure could be long, right? Like a Mohs surgery, if you go many rounds of Mohs surgery, that could be half day or whole day. But if you say, well, your skin cancer has some invasive component, but also some like a superficial or maybe we call squamous cell carcinoma in situ on the periphery. So maybe your goal will be just get rid of really aggressive part with surgery and leave the less invasive part for topical treatment or adjuvant radiation, things like that. So it's like you cannot simplify that. And also think about how can patient care for their wound, and sometimes even the skin very thin on the chest, you can still close it with a linear closure or a flap or graft closure, like borrow skin from anywhere on your skin, somewhere on your skin. So there are different ways to close the wound instead of leaving it open, and let it heal. Or even though let it heal on the chest by Mother Nature is actually okay. It's just a lengthy wound healing process. But the wound care is simple. If you have a good caretaker, it's just Vaseline and until it kind of filling and scab over. So it's a complicated discussion, but obviously radiation oncology will give you another way of option as well. So Adam, you take over.
Yeah, I agree. I think this is a discussion we have all the time. I think we're really lucky at UW that we're all really collegial, and we're all busy enough that we don't compete with each other, and so we're all just trying to find the best answer for any given patient. And it may be that radiation's the best. It may be that surgery is the best. It may be actually that cemiplimab, an immunotherapy drug, could be the best here, because you kind of then kick the can down the road and you don't commit to either local therapy, treatment. What I would say about radiation is radiation and surgery are very different. And so how I usually counsel patients to think about it is hear from your surgeon, hear from your radiation oncologist. I tell them to discuss what we've talked about in clinic on the way home so that everybody's got the story straight. And then I tell them to try to forget about it for a couple of days and come back to it on the weekend. And most people your brain will naturally have a pretty strong opinion about surgery versus radiation. That just seems to be my experience. And so people are rarely left with a lot of doubt or a lot of indecision about these types of decisions. But I think the key is that you let the thoughts kind of breathe. You let the information breathe for a couple of days after you've sort of got your story straight and seen your radiation oncologist and surgical oncologist in clinic. So I think that once you meet a radiation oncologist, you get a sense of what they think the side effects are going to be and how they think this is going to heal. You're going to have a really great direction in terms of which way to go, whether it be surgery or radiation, but both are possible in 96-year-olds. And cemiplimab, is something we would commonly consider in this instance as well. And Vince is well aware that we drag him into these cases all the time, because often that's the answer. Often that's what people prefer. And we can almost always find kind of a best fit for each person.
Yeah, and just to kind of echo on what Dr. Burr said, I mean, what I really love about our institution here at University of Wisconsin is, I mean, we're a very collegial group, you know, we're very multidisciplinary. We'll oftentimes discuss these complex cases in our tumor board. And so, you know, every patient case is unique. And so we always take into account, you know, many factors like age, medical problems to really decide on sort of the best or optimal treatment. And so, you know, as you talk about surgery and radiation, you know, we're now entering a field where we're getting more comfortable using things like cemiplimab, which is another immunotherapy drug used to treat squamous cell carcinoma, is now being introduced even earlier on in terms of the treatment plan. And so I didn't talk too much about it, but age in itself is not necessarily a hard cutoff of using that therapy. And so, you know, it's always important, especially for these very complex cases where you can't really decide what is the best option. It's never the wrong idea to kind of meet with a multidisciplinary team to come up with the best overall treatment plan. So moving on to maybe a last couple of questions. Maybe one that I think would be very interesting for Dr. Xu to maybe answer, but there are so many apps out there that are used to offer and diagnose skin cancer. From your perspective, Dr. Xu, as a dermatologist, and do you have any confidence in this new technology that's been flourishing more recently?
Oh, that's an awesome question. There are a lot of apps out there, but I don't think any of them actually has like enough long-term evidence to show that, hey, you know, I think the best way to, like in a research environment, I would think, you know, you have an app, you diagnose, you know, skin cancer or no skin cancer, what kind of skin cancer, and hopefully we can see the patient in the clinic, you know, and get some biopsy-proven skin cancer. And then we can actually see like any test, you know, how good it is, you know, how specific it is, how sensitive it is, that can be tested in that kind of, you know, more defined research setting. I'm not aware of any apps that kind of gone through this rigorous process of testing and, you know, in the trial period time of time. You know, so I think, you know, I'm aware of a lot of, you know, apps and also, you know, I can look at your mole and look and see like if which mole is more suspicious for melanoma, for example. That's available as well. So, but I have to say, it's not like I'm against it. I mean, technology, particularly with the AI, you know, and it's going to be a very powerful tool, both for medical professionals and also for laymen, you know, for patients. But I think it's in evolving period right now. Like I cannot name any specific AI APPs that I think can be used with confidence at this point. But I'm very hopeful it's going to come.
Yeah. Sounds like the future might be coming up soon at some point,
Yeah,
but that'll be very exciting for sure. Maybe we'll answer, I think this is a very good question, especially for the community. Maybe Dr. Xu, if you want to just highlight very briefly, if you can, is there a specific brand or maybe even ingredient of sunscreen or sunblock that a dermatologist would often recommend? And, you know, people often worry about what is absorbed into the skin versus actually what's being used for protection.
Yeah, I think there's so many brand names. So like, you know, we kind of teach our residents, medical students the same way. Like we don't actually specifically say which brand, but we can say the ingredients, right? You know, for example, for ingredients, as I alluded in my slide, there are physical blockers and there's no chemical absorbers. So physical blockers will be, you look at the your sunscreen bottle, you know, tube, it says like zinc oxide or titanium dioxide. And they actually will say that it's a physical blocker. Some of the sunscreen will say that. That you actually know it works just by blocking sun rays, you know, so nothing absorbed into your skin if you put enough amount on. So that tend to be less allergic reaction, as I said. So I would say like, you know, some people might just want to look at the ingredients and also look at the number SPF, right? But in terms of specific brand names, you know, we don't favor one over the other.
Excellent. And maybe I can answer one last question, just about Merkel cell. That's all right. So someone did ask, did I say that polyoma virus detected can make prognosis better. And so, yes, I did mention that in one of my slides. And so sort of the detection of Merkel cell polyoma virus in the tumor actually is a bit controversial in terms of like, how do we properly test for the virus? You'd be surprised that actually there's a lot of controversy of how do you actually assess it, because people can be infected with the virus and it may not necessarily be the culprit, of the cancer itself. And so, when I say that the prognosis is better, now, this was really mentioned in an era where we really didn't have much in terms of treatment. This was sort of the conclusion that was determined, several years ago. And now that we have newer drugs available, for example, immunotherapy, other chemotherapy drugs, we're noticing that, for example, as we're treating patients with it, we're not actually seeing differences in patients who, for example, have the virus or not. There's been some studies to suggest that, there is actually no difference at all in terms of survival or response to immunotherapy if your Merkel cell tumor has the virus. There are a lot of, studies right now being done on Merkel cell to really identify markers or prognostic markers to know, for example, if you're going to have a better survival outcome or better treatment response. But the thing is that, again, Merkel cell is so rare, but we need more patients to participate in studies in order to us better understand sort of these prognostic biomarkers. But with that being said, I do want to say to thank you all for those who were able to attend our virtual symposium this evening, including those on YouTube and Facebook Live. And so I'd also like to thank sort of the organizers of AIM at Skin Cancer, including you, Anne, for inviting us to present today. And then we obviously hope that everyone had an opportunity to learn something new about skin cancer and can hopefully apply some of that knowledge either to yourselves or your loved ones if you've ever been diagnosed with skin cancer. And so with that, I guess we will close our session.
Good evening,
Thank
Tim.
you all.
Thank you for joining us.
Thank you all.
Thank
Thank you. It's been a pleasure.
Thank you.